There we go. And if you have any issues with sound or anything, please do let us know. So we just wanted to start off with an update. We now have 267 patients randomized to the trial, and we have 22 sites now open to recruitment. So quite a few sites have joined us recently. Musgrove Park were greenlit last week, and then we also have Southampton General, Royal Glamorgan, and Down Valley all joined us in April. And just to reiterate that we've got another bank holiday at the end of this month, but recruitment will remain open for all three interventions. So before where we paused it, now recruitment will stay open throughout the next bank holiday weekend. So I'll just hand over to Dr. Silversides just to go over the fluid intervention.
Right, and right on cue, my computer has tried to load an update, and now I've lost the slides. So give me 1 second to get those back.
Okay, no worries.
Couldn't have happened at a better time. Um, yes. Okay. That sort of works. And Paulina or Ravinder, Ravi, are you gonna
Yeah,
change the
I'll
slides?
change the slides if you let me know, and then I can
Okay,
move them
great.
along.
Okay. So good to see. Well, I was going to say it's good to see everybody. Most of you are hiding behind switched off cameras, and I can't see you, right? But I know you're there. So we'll chat through the fluid intervention, and the idea here is to make this pretty informal. So please jump in with questions if there are things if you have questions or if particularly if I'm not explaining things very well. So yeah. Great. First of all, as you know, the fluid intervention is just one of three. But I guess it's probably fair to say that it might be the one that seems to generate most questions. So, is that fair, guys? Probably. Maybe it's just my impression. I don't know. Anyway, we'll work through it and see if we can address some of those things. Now, I'd hope that Catherine Ward, who's one of our senior research nurses from here in Belfast, would be able to join and help me with this, but she's had to do something else. So you're stuck with me. Okay, so we're looking for a lot of patients, 3,758 to be precise, and that's a lot. So I guess one of the key things is that we need to think about how that's a lot of work for everybody, for the center, for sites, for all of you. So I guess we need to make this as smooth as we can and try to minimize the barriers and the challenges to delivering the intervention if we're going to do it in a large number of patients. And I guess that's about changing and embedding this within standard practice to some extent. So next slide, please. Okay, so I'm not going to go through every criterion here. I guess one that maybe confuses people a little bit is this one of these inclusion criteria, which says that according to local clinical judgment, a patient has received adequate initial early fluid resuscitation. And I guess I wanted to explain a little bit what that means. So if we think of another slide just after this, if you don't mind, which might explain it a little bit better. Okay, so we think of fluid management as four phases, and this has been described a little bit in the literature. There's the initial, oh my goodness, the patient's really sick, squeeze in some fluid and as fast as possible in order to try and provide some kind of stability, that kind of rescue phase. And then there's the phase where we're looking at the patient a little bit more carefully. Maybe vasopressors have already started, and we're optimizing. Okay, so we're looking at the patient going, yeah, I think maybe they might need a little bit more, or I'm not sure a little bit more fluid is going to make any difference. So what we're trying to do is get people who are past the immediate, oh my goodness, the patient's really sick phase, and they've had the initial fluid bolus. We don't specify any particular amount, but once we've given that first few fluid boluses, so that the bulk of the fluid resuscitation is probably done. That's the point. And that's often long before they come to ICU. It's very unusual in my experience that the patients are still in that rescue phase in ICU, unless you're very, very good at getting patients into ICU very quickly, which I think is probably not the case in most ICUs around the UK. Then by the time they hit ICU, they're into that optimization phase. Okay, so don't think that this isn't some there isn't some magical formula about when initial early resuscitation is complete. If you're not squeezing in fluid, then that's done. Okay, that initial phase is done, and the patient's eligible for the trial. Okay, any questions on that? Okay, so we're aiming to take over and I suppose tweak the way that we do the optimization phase, and then continue that through the stabilization and move into deresuscitation. I suppose we're probably, compared to usual care, we're probably trying to bring the deresuscitation or de-escalation phase forward a little bit and do it earlier so that the patient is exposed to fluid overload for less time and are euvolemic for at an earlier stage in their journey. Okay, next slide, please. All right. I don't think there's anything terribly exciting to say about these exclusion criteria. Just for the avoidance of doubt, I suppose the not expected to survive 90 days can sometimes cause confusion. That is due to pre-existing chronic disease, and that would be pretty rare. I think in the UK, we're not likely to admit people to the ICU whose life expectancy is less than 90 days. So really, that's not somebody who's really sick, acutely sick, and unlikely to survive. It's the patients who have a chronic disease and are really in a terminal phase of their chronic condition and unlikely to survive 90 days. So that should exclude almost nobody. It's really pretty exceptional that those patients would make it to ICU. What's perhaps a little bit more likely are those who are not expected to survive initial resuscitation, but we're really saying 24 hours. So that's a very small number as well. Most patients who die in the ICU it'll be a longer time period than that. Okay, so these shouldn't be excluding large numbers of patients in your sites. And if you're not sure, please just get in touch with the team. Okay. If we think about what we're trying to achieve, I suppose if we imagine some of those patients so you may be concerned about patients who you perceive to be at high risk of death in the ICU. I guess we're trying, if any of our interventions work, what we're hoping is that some of those patients we're going to move from, who are very marginal, might move from not surviving to surviving. So if we exclude them all, then we'll never know. Okay, so really important that we do apply these criteria as generously as possible to get a wide range of people into the trial and only exclude those who are really moribund and actively dying, either from chronic or acute disease. Okay. Anything else from that? I know that the source of infection does come up, and really we're just trying to exclude those patients who really do have evidence of a source of sepsis, which is going to require a prolonged course of antibiotics. So not just, it's possible that they might need longer, but there's a really good reason to give them a long course of antibiotics, an undrainable abscess, for example, or endocarditis, that kind of thing. Okay, next slide, please. Okay, so this is what we're really talking about today. So as I've said, the idea is to start this as soon as possible. As soon as we get past that initial squeezing in the fluid bolus stage, we're ready to randomize, and we want to address the fluid balance and fluid intervention as early as possible at that stage. So remember that, so from previous studies, I'm thinking particularly of the Classic and Clover's trials, in the US and in Scandinavia particularly, we know that there's probably a bit of a, rather than a need to give fluid for every possible opportunity, we know that a restrictive fluid strategy is safe, and just as good as what we normally do, which is give fluid until there's a really really good reason not to. So we'd like to restrict fluid in the intervention group, and the idea is to only give fluid if there's a really strong indication. Those strong indications are listed here. So overt signs of hypovolemia with skin mottling, and the best place to look for that is the kneecap. It's a bit odd, but that's where the skin is really thick and where skin perfusion tends to go wrong first. So it's a really sensitive indicator of poor perfusion. So if there's an area of skin mottling beyond the area of the kneecap, then that's okay to give fluid bolus, and generally that should be 250 mils of balanced crystalloid. If you can't, so being on noradrenaline itself is not an indication to give fluid. Patients are vasoplegic. Noradrenaline is the appropriate treatment for that. And it's only really if you can't maintain a blood pressure target despite an escalating dose of noradrenaline or other vasoactives that a fluid bolus would be indicated in this restrictive group. If the lactate's greater than or equal to 3, that's a reasonable indicator, and try and see if it helps. And if the urine output is less than 0.25 mils per kilo per hour on the first day. After that, the AKI is probably established. You're probably not going to do much good with fluid, okay? And reassess after each bolus. So give it 250 mils, see what happens. If it isn't working, stop. We're very good at doing the same thing repeatedly and expecting a different outcome. Fluid, if it's going to work, it'll work early on. It doesn't work later on. We know that the chances of being fluid responsive after about 8 hours in the ICU are probably in the order of 10% in a septic population. It's really quite unusual to be fluid responsive after the first few hours. So if the first few fluid boluses haven't worked, there's no point giving any more. Okay. We want to not give maintenance fluid. You can feed the patient as normal, that's fine. You can replace blood or other fluid or drain losses replace on a one-to-one basis. Okay. Next slide, please. Okay, so that's the conservative fluid administration side, and then we move on to the other side of the coin, which is de-resuscitation or de-escalation. So from the second day, so on the first day, we start to fluid restrict. Second day, we're looking at the patient to see if they need to be de-resuscitated or if there's an indication for de-resuscitation. So the first question is, are they cardiovascularly stable? And that's defined, as you can see here, on the basis of a noradrenaline or norepinephrine requirement. So less than 0.2 is sort of moderate dose and not increasing. So they have to be stable, first of all, and then there has to be a reason to give them de-resuscitation. We don't think this should be applied blindly to everybody. It's only if there are signs of fluid overload. Okay, and we've defined that slightly arbitrarily as a 3-liter positive fluid balance from the time of ICU admission, or edema in more than one site. It's probably the edema that's more important. So we want edema in more than one site. We know that, for example, if you have an injury to one limb, for example, you may have edema on that side. Previous CABG with a vein graft, that limb may become edematous. That doesn't necessarily reflect the global picture of fluid overload. It's a local thing. So if it's one site, we can ignore. If it's 2 or more, then we should treat that patient as fluid overloaded. And then de-resuscitation is only indicated according to the protocol if there's both stability and signs of fluid overload. If we do start that, then we're aiming for around a negative fluid balance of around 1 liter per day, and that's using an indapamide and a furosemide bolus followed by infusion. We know that practice varies with regard to diuretics, and we're trying not to be too prescriptive. The reason for the indapamide is that it will help with natriuresis and helps to prevent the hypernatremia, which is pretty common when you give furosemide on its own. You can use another thiazide if that's your preference. It really doesn't matter too much. Give a thiazide along with the loop diuretic, the furosemide. Okay. No, common practice is probably to give more spironolactone than thiazides. You can do that as well if you want. It's not part of the protocol, but it wouldn't be a deviation if you did do that, but it's not part of our algorithm, largely because it's less effective at causing natriuresis than a thiazide. And again, we want a bolus of furosemide, 0.25 milligrams per kilogram, followed by the infusion, and that's titrated. We've got an algorithm for that. Yeah, aiming for a liter negative per day. If the patient's on renal replacement therapy, you try to achieve the same thing using CRRT or intermittent dialysis, according to your unit of practice. And that should be reassessed daily. So every day, those questions about is there fluid overload, or is there stability, and is there fluid overload, and only continue the deresuscitation if both of those conditions are met. Otherwise, stop it and reassess the next day. Okay. Any questions so far? I can't see any of you, so I can't really tell if you're still listening or. Okay, maybe I can make the screen bigger. Any questions about any of that? Clear as mud. Okay. Good. Okay, we'll press on. So next slide, please. Yeah, so as I said, I think I went through this already, so probably don't need to cover it again. Sorry, next slide. Yes, absolutely. So I'm glad you asked that, actually.
Thank you.
First question is about the diuretics. So the 5 milligrams of indapamide on its own probably isn't going to do very much, to be honest. It's there to supplement the furosemide, which is the main thing, I guess. And it's really just to help with that natriuresis. So the idea is that rather than just making the patient pass lots of urine which is largely free water, which is often what happens with furosemide, you get rid of sodium and water in proportion. And we know that our patients are massively sodium overloaded. We give them tons of salty water in the form of fluids, and then we give them lots of drugs which are made up in salty water. So we know that getting rid of sodium is really important. Otherwise, they just end up hypernatremic. So it's really that's the rationale for it. And I wouldn't. And the idea is to, the exact timings don't matter too much. So the infusion can wait for a couple of hours until the bolus has probably, the diuresis from the bolus has passed its peak, if that helps. But it's really just the problem is sometimes that, patients vary in their response to a furosemide bolus a lot.
Yeah.
So sometimes the bolus on its own won't do anything. The infusion is really just to follow through and make sure that they do achieve that negative fluid balance. It can always be stopped once that negative fluid balance is achieved. Just stop it. There'll be a little bit of a lag, I suppose, before it wears off. But as long as you're watching it, I mean, these things are very, very, very safe, and I wouldn't be anxious about that at all. In terms of the AKI, so this is I'm really glad the chance to address this, because this is largely a myth. Okay, so diuretics are not nephrotoxic. They're just not. I mean, there's a little bit of evidence that furosemide, for example, actually is in high enough doses is protective against AKI.
Yeah, I thought that. Yeah.
So unfortunately, we can't give it in high enough doses in humans to probably benefit from that protective effect. But so sure, if you cause hypovolemia, and we're going to come back to the algorithm, I'll show you how we try to avoid that. But if you cause hypovolemia, sure, okay, you can cause kidney injury, but we're not trying to do that. We're not trying to apply this as a blanket approach. We're trying to gently bring the patients back from fluid overload into a sort of a euvolemic state. And I think if we do that properly, then there isn't a risk of AKI. In fact, there's a systematic review, which I think we referenced in the most recent newsletter, which actually shows that deresuscitation is probably the one outcome for which there's most evidence is in AKI, in prevention of AKI.
Oh, brilliant. I'll quote that. Thank you.
Yeah, please do. Fluid overloaded causes venous congestion. Venous congestion in the context of an encapsulated organ like the kidney reduces the perfusion pressure gradient and will reduce filtration. So there's reasonable evidence now that fluid overload is not a good thing for kidneys. Yeah.
Brilliant. Thank you very much. That's answered my question.
Thanks. Any other questions? Okay.
No.
Grand. Okay. Well, let's go back to the slides and yeah, there we are. Okay. Nope. Sorry, my screen is messing about now. Right, here we are. Okay, here's the algorithm. That's not particularly clear, at least not for me. So let's zoom in a bit. Next slide, please. Great. Okay, hopefully you can read that. I'm getting to the age where I'm squinting at these things now. Okay, so just to go through this in a bit more detail, patient is randomized to conservative fluid management. That's the start of day 1 of the study. And here we're aiming to fluid restrict and wait for a period of stability to consider deresuscitation. So no routine maintenance, concentrate the drugs as far as you can, and avoid IV fluid boluses unless there's an objective sign that may represent hypovolemia. And that's those things I've mentioned before, the skin mottling, the unable to maintain blood pressure despite norepinephrine or noradrenaline or some other vasoactive lactate and urine output. Okay, and you can use the mottling score. So here's roughly what we mean by that. So the kneecap, anything outside of that is criteria, meets criteria for giving you some fluid and seeing what happens. Okay. All right. You might get so part of the problem here, I think, is that let's be honest, we're all looking for ways to make our lives easier, and it's certainly as a doctor, it's much easier to say give 250 mils of fluid than it is to go and examine the patient and look at their skin perfusion and say, actually, they're okay. Let's just sit tight. It's much easier to react than not react. And I guess, even outside of this study, what I think is really important is that people think about this and don't just do that knee-jerk for any indication. The answer is 250 mils of fluid. Yeah. Okay, next slide, please. Okay, so then so we're through day 1, which is from randomization until the next morning, and then we're starting at day 2. 2 questions. I think we put them the other way around before, but basically the 2 criteria need to be met: cardiovascular stability and signs of fluid overload. And if both of those conditions are met, then we would give deresuscitation. Okay, a couple of problems that could come up. We saw this in our pilot trial. So metabolic alkalosis is reasonably common. If that does happen, you can add in acetazolamide. It'll generally resolve that pretty well. And hypernatremia, which can be a problem despite the thiazide. But you can treat that according to usual practice with NG water or 5% dextrose, and consider increasing the thiazide to get more natriuresis, get rid of more sodium in the urine. Okay. Next slide, please. Okay, so we're just to say, yeah, we're aiming for a liter negative per day. A little bit more is fine. Yeah, I think that combination therapy is important. So there will be patients, of course, who can't take enteral drugs. I would say most patients giving an indapamide tablet down the NG tube isn't going to do any harm. There will be exceptions to that, of course. Somebody with a hole in the stomach or something like that, you really might not want to put anything down at all, that's fine. But the vast majority of patients, even if they're nil by mouth, putting a tablet down there and is unlikely to do harm in the majority. But obviously, that's a question that you bring to your clinical teams. Then reassess daily up to the morning of day 5, and then or ICU discharge, and then stop the protocol. Stop the diuretics. Yeah. Next slide, please.
I'll just jump in here, John. We've just had a question in the chat.
Great.
So a site has asked that they had 2 patients with established AKI and high creatinine in the 400s. Would these kind of patients be suitable for diuretics? Would diuretics work on them?
So I guess going back to what I said before, diuretics are not nephrotoxic. If the creatinine is 400, chances are they may well not respond very well to the diuretics. You can give more, and that's absolutely fine. Furosemide to those patients. Weirdly, in ICU, we're much more anxious about it. So you might need higher doses to get a response. It sounds like they may well be heading in the direction of renal replacement therapy anyway, and that sort of makes it easier in some ways. But it's not a contraindication as long as the patient's not hypovolemic. But I think we've said that in the protocol anyway. So you shouldn't. This is not a blanket approach. This is, you look at your patient and you use evidence to decide if the patient's overloaded, and then you apply the resuscitation algorithm. Yeah.
Okay, great.
Any other questions?
No more questions, I don't think.
Okay. All right. Standard care is easy. Do whatever you would normally do. In terms of fluid boluses, I suppose we've defined that according to SSC guidelines very loosely, and we know this is applied differently in different units. It's basically give fluid boluses according to response, applying fluid challenge technique, and that really is there's a lot of variability in how that's applied, I guess. If you normally give diuretics, you can give some diuretics if that's clinically indicated. We won't sort of stop you from doing that. Yeah. Next slide. Okay. So this is really difficult. We won't pretend otherwise. The fluid management is one of those things that everybody thinks they know and everybody thinks they do well. And I'm not here to tell you that we or I know how to do it and nobody else does that. It's not like that. The answer is we don't know the right way to do fluid management, and that's why we're doing the study. There are lots and lots and lots of different circumstances and reasons why people use to give fluid. Everything from there's a tachycardia to blood pressure to urine output to skin perfusion, to the patient's to there's a swing in the arterial line, to the monitor told me to give fluid, to there are a whole ton of different reasons that people use. Okay. And the reality is we don't know the best way to do it. Okay. In terms of the fluid restriction arm, this is pretty close to a strategy which was tested in fact, it's less restrictive than that which was tested in the classic trial and shown to be safe. Okay. So we know that the algorithm is safe. That is in terms of fluid restriction. We're aiming to compare that with usual care. If we do usual care in both arms, we don't have a trial. So we know this is sometimes difficult. You're convincing people you're asking people to do things that they don't normally do. But I think acknowledging just how little we know about the best way to give fluids really important. And having the humility to accept that. We're testing a strategy which, at least part of it, is the conservative fluid approach we know is safe. The deresuscitation part of it is less well proven, but the evidence we have suggests that maybe it's safe and maybe beneficial. So this isn't just plucked from thin air. So it's really important that we do the trial to find out if it helps for patients. Okay. Next slide, please. Yeah, what if they don't want to do it? I guess the answer is the same. We're doing this study because we think it may help our patients. It's based on the available evidence. Yeah, I'm not sure what else to say about that. Yeah. Next slide. Yeah, we know that there are different ways to give diuretics. So could you give it as a bolus rather than infusion? We'd really like you to give the infusion. And the rationale for that is that boluses often don't get given. So we'd like you to give the infusion after the initial bolus, loading bolus followed by infusion. We think that has the best chance of achieving the negative fluid balance, which we're trying to test in the study. And yeah. We know there'll be some circumstances where that might be really difficult. So, for example, you might run out of lumens in the central line. Do what you can. Follow the protocol as closely as you can. If you need to give boluses instead, just record the reason for that and accept that. But it's better to achieve the fluid balance however you can rather than not do it at all. So, yeah. Okay. Next question then. We don't normally use indapamide. That's fine. Yes, use whichever thiazide you'd like. Yeah. Okay. Next slide. Yes, patients who are nil by mouth, particularly if it's an ileus, you're not you need to run this past the clinicians who are looking after the patient, but you're really not likely to cause harm by sticking a tablet down the NG tube. It's more of an issue for those rare circumstances where, I don't know, the stomach has a hole in it, it can't be fixed. That's a bit different, but most patients really putting a tiny little tablet down the NG tube and spigoting it off, or it isn't going to do any major harm. Okay. Or any harm. All right. Next question. Okay. How to educate science staff. And I was really hoping that Catherine, who's the research nurse here in Belfast, was going to join me for this. But I guess before I start, does anybody want to share their experiences or want to talk about what's worked at your sites? Because I think we can probably all learn from each other on this. Great, I see a couple of hands. Brilliant. Sarah?
Hello. Hi, I'm Sarah. I'm from Imperial College of London, and I'm working in St. Mary's. We have been running the study for longer than a year here in St. Mary's. So I think maybe we can give a little bit of outside from our point of view, how we've been doing things since we started, because we were the very first people to start with the study and with the flow chart. And I agree that it can be very challenging at the beginning, especially because each ICU has their own culture, and it's a little bit tricky sometimes to kind of break that down and trying to implement something new. So from my experience, I think it's all a lot of talking, but always reassurance them that you're going to be there for them and you can answer all the questions. And especially with the doctors, I like to try to explain at the beginning of the day what is expected from them. So before they do the ward rounds, I approach the team and I explain to them the flow chart and make sure that they are comfortable navigating through the flow chart and the algorithm. And for the nurses, I always try to get the flow chart next to the patient in bedside and also explain to them. Funny enough, after a year, I can tell you people get used to it and they like it. And actually now they really avoid to give fluids, even if the patient is not on the conservative fluid management, because we can see that actually it's not difficult to do. It's something that we should be doing anyway. And it's quite safe. And actually I can reassure the sites that they're starting just now really safe and I haven't had anyone who is been in danger because of the flow chart, because of the conservative fluid management. So another thing I wanted to say, sorry, I didn't want to actually interrupt before, is that people is very scared of the furosemide, and they normally actually tend to give the boluses rather than the infusion. Actually, we like the infusion more now because you can control hourly, you can monitor the patient hourly. ICU patients get monitored hourly anyway, and we can tell very quickly if the flow chart, sorry, the balance is going to the right direction. And because also the ICU nurses, they do know that if something is unsafe, we can stop straight away. So we actually have more control of what's happening with the patient if we have an infusion. You can give pulses if you want, but once you give 20 milligrams of furosemide, then you cannot do anything. While if you actually start the infusion and slowly see how the patient is getting negative, you can stop the infusion whenever you want. So that's my experience. Anyway, as I said, each ICU has a different culture, so it takes time, but trust me that you will get there. I don't know if I help a little bit, perhaps.
Yeah, that was really helpful, Sarah. Thanks so much. It's
No
it's a
problem.
common question that we get in SIVs, and we've got quite a few new sites opening now, and I think it's just helpful for you to provide that site perspective that we might not be able to give. So that's
Yes.
really insightful, and especially because you've been open for a while and you've been through the process with quite a large team. So we often get that question as well from sites that have large teams, how do you educate everybody? But yeah, if
Yeah.
anyone has any, I don't know if we've got any new sites or ones in setup, but if you have any questions, please do pop them in the chat. That was really helpful. Thank you. I think we had another hand up from Natalie from Kettering.
Yeah, hello. Just to sort of reiterate what Sarah just said, excuse the very long camera view there. People I feel are just very reactive. As John stated, it's easy to try and just do something that you're used to. So the way we kind of go about it here at Kettering is just teaching, lots and lots of teaching. And we reiterate to every single doctor that comes onto our unit that every patient who enters the Kettering General Hospital or any hospital across the NHS Trust has a right to be involved in research. So them doing it or not doing it because of their own personal feelings isn't actually ethical. There's a reason why we're doing the study. There's a reason why we're trying to figure things out. It's because we want to be the change in practice that we want to see. So the way I kind of word it is, it's their personal right to be involved, but at the same time, fluid, although we use it regularly, is still putting something into a patient. So there's infection risks. There's all sorts of risks of things we do, even if it's a simple thing like putting cannulas in, giving fluids. Just because practice is normal doesn't mean it's correct. So it's just reiterating why we do research, why we're important. So just lots and lots of teaching on the shop floor. putting our numbers out. Obviously, we've got bleeps and stuff here for research, thankfully. So yeah, it's just mostly teaching, but it's just reiterating the patient's rights as well, because we're there for the patient's advocacy, especially within the intensive care setting. So I think the easiest thing to do is play on heartstrings. And it's kind of like, they deserve to be involved. Just because you don't agree doesn't mean that you are correct. We're doing this for a reason. The patient would consent to this unless family suggests otherwise, or if the patient wakes up and suggests otherwise. So I think being fully ethical about it, and mentioning that to doctors, because I've noticed a lot of like the FY1s, FY2, they try and do things by the book, and it's what they're taught. It's what they're taught in medicine. So it's just trying to break that status quo and just teach them that it's okay to not do things as you're taught textbook, because sometimes it's not necessary. And it's also safe to not give something, actually, because you could do them more harm by giving this fluid, which is obviously what we're trying to reiterate with this trial. So yeah, just lots and lots of teaching on our side. That's it, really.
Thanks so much, Natalie, for giving your insight as well. It's really helpful, to have that input, and a good point about, this is what we're investigating, and yeah, like John said, we don't really know the outcome of it, so it's what the intention of the trial is. Just wanted to check. So John's just had to pop out for a minute, which is fine. He's just in theatre today. So just want to check if there's any other questions, maybe some of the newer sites, if you have any queries for some of the sites who've been open for a while in terms of processes. Hi there. Or if you have any other clinical questions, you can put them in the chat and we can flag them with John after the meeting even. Oh, just thank you. I see John's go back.
Sorry about that.
That's okay. We had some helpful input from Sarah from Imperial and Natalie from Kettering, just kind of how they manage educating site staff about fluid intervention, and Sarah just reassuring others on the call that it is safe, and it's working quite well now that they've been open for over a year, and it's very well established, and everyone's quite used to it. So just checking if anyone else had any queries or concerns about the intervention. We're quite keen to hear from you. Or if you have any other clinical questions for John.
I think this is it does require a fair bit of education reprogramming, I guess. We've been programmed to think that fluid is relatively harmless, and there's a ton of evidence that fluid overload is associated with harm. So it does require a bit of asking people to rethink what they already think they know. But I think where the key is to approach this in a use that word humility. I guess I think it's really important. We don't, so that we know this intervention is going to be better. We don't know that. We know that it's the evidence that we have so far suggests that it may be better than what we typically do. And we want to test it and find out. If people really believe that their usual practice is better, then well, let's do the trial and find out. So that's how I'd approach it.
Thanks, John. I'll just wait and see if there's any other questions about the fluid intervention before moving on.
I think we did have, wasn't there a question that I think one site sent us? It was along the lines of, well, all our patients seem to end up 5 letters positive no matter what we do. How do we fix that? Well, again, how do we know that that's good practice? We don't. So again, it comes down to, well, let's see if doing this differently might be better. We don't know that. Yeah, that uncertainty is important. Sorry, I feel like I'm saying the same thing a lot, but it's a hard point to get across sometimes.
Yeah, that's okay. It's just perhaps reassuring, or hopefully, we hope that it's reassuring to our sites as well, hearing this, and especially from other sites, such as Kettering and Imperial. Okay, I'm just conscious of time. So the rest of the webinar is just a few study updates. But again, if anything comes to mind, please just pop it in the chat as well. So we just have a few, just going over a few study reminders. Apologies for any of our sites who've, kind of heard this information before on a previous webinar, but we just thought it'd be helpful to reiterate to any of our new sites that have joined us as well. It's just to go over some of the randomizing and data entry on Open Clinica. So this is kind of like a quick video of just the final part of randomizing a patient. You've completed all the screening forms, quite eager to get the allocation. And we have this last form, which is called randomization confirmation, which I'm kind of completing here on the screen. And then you click yes, you've entered your date of randomization, which is today's date. Clicking randomize. And then everyone's kind of familiar with these steps. You click complete. And then I'll just kind of show what happens if you wait for the allocation. So if you wait for the allocation, you can see I haven't gone into the form, but it's automatically updated by the system. So it's turned from blank to orange. You can see the system has added some information. So now I've gone into the form and I can see my kit allocation, but it would be the same for diagnostic or fluid. This is just one example. So all the form is populated. There's nothing for me to do except for note down the kit number, and then that kit would need to be administered for this specific patient. So I'll just show in the next example what happens if we don't wait for the system to update this information. So again, this is just the final stage of randomizing the patient. So we'll just go through this final stage of clicking randomize. And then I'll just show you what happens if you click on the form straight away to see the assignment. You can see underneath treatment, it's blank. So treatment is just the subheading of that box, but really there should be an allocation there. So either for the diagnostic intervention, the fluid intervention, or for GMCSF, you would have the kit code there. And then this is, if you get stuck, you can come out. And then when, if you get stuck and you call us, these are the stages that we usually talk you through, going back in on the edit mode. And then you'll be able to see your allocation. So what happens is when we open the form a bit too quickly, the information hasn't had a chance to populate in that form and it just gets a little bit stuck. So that's why we have these steps to kind of show you how to fix the allocation. But if you really are stuck and you're not having any luck, please do give us a call, like one of the SepTiC team. We're more than happy to talk you through a randomization as well. And then just a few other reminders about data entry. So we've got our SepTiC ECRF completion guidelines as well. And we do recommend that they are very long, but say if you're completing a specific form on Open Clinica, perhaps you can have it open on one page with Open Clinica open on another page. And just a reminder about the date of visit. So this is that extra form that sits on the side of all of the CRFs. This is the day that visit took place. So if you're filling out the day 3 ECRF, the date of visit is when the day 3 happened for that specific patient. It is not the day that you are completing the form. And also had some questions about for data entry, when is baseline and when is day 1. So I've just taken this from our FAQs. So the baseline is up to randomization, and day 1 is from randomization until the end of the chart day. We have covered this in one of our webinars in detail, so I would recommend watching it. It's the one from the 11th of November, and it's specifically about data entry and Open Clinica. And then just a few other quick reminders that we wanted to add is just to make sure that you're using the latest versions of the PIS and the ICF. So these were updated in the Amendment 6. And also, if you are approaching a patient for consent after randomization, please do use the retrospective patient consent forms. We have also recently circulated a new randomization and troubleshooting guide. So this has some extra FAQs and extra help points, and we're just hoping that that will help any sites with overcome any issues with randomizing as well. And I think everyone usually does get in touch, but just as a reminder to please do regularly check your consumables. Some of the tubes expire at different times. For example, the Paxgene tubes have a bit of a shorter shelf life than the other tubes. So please ensure that they're all in date and get in touch with us if you need any new tubes. And just to keep an eye on our SepTiC FAQ page, I think we try and keep you all updated via webinars and newsletters, but also would just direct you to the FAQs if you have any questions about co-enrollment or anything else. And again, just a reminder that all of our webinars, including this one, will be added onto our website. And you can also access all of our previous webinars via our YouTube page. So just a final point is, obviously we gather a lot of feedback through phone calls and emails, but your feedback is very important to us, and we are really interested to hear how recruitment is going and any particular challenges. So we will circulate a link to a feedback form after the webinar. So we just want to hear, how is recruitment going at your site, and what are any barriers or challenges to recruitment? So please do use the form to get in touch with us. And I'll just stop sharing just to check if there's any last questions before everyone drops off. If not, or if don't feel comfortable sharing on the webinar, that's not a problem. Feel free to drop it in an email, or, you can always give one of the SepTiC team a call. But we just want to say thank you all so much for all your efforts with recruitment lately. And we're excited to have so many sites on board and sites in setup. So we're really valuing your input, hence the feedback forms as well.